you guys do some of the talking. And so we're going to start it out just like we did yesterday. So there's 34 blanks. I want you to fill those out in the next 5 minutes and put all the answers in before you even know the questions. Of course, Steve doesn't even have a sheet. No, Steve, don't worry about it. Right. I'm impressed they all got the answer sheet before others didn't do. In med school, we would call this gunners, because they were always shooting for the top grade. So they always had the answer sheet ready to go. Don't worry about it. Now the key is also to make sure you do put your name on the top. Even in medical school, brilliant people get forget to put their name on it. Don't worry about the answer sheet for a while. We're going to do, I want to hear from you and I want to hear your challenges. And this is where you guys do most of the talking and I don't. And we're going to talk about some things that the crews brought up yesterday. So, like, Bob, how are, out in your area, Bob, tell me about how traumas, how are the aircraft summoned? Tell me, how is that interaction going? Because out in the rural communities, this seems to be more and more of a problem. Do we go to a local hospital? Do we go all the way to a trauma center? Which cases, that sort of stuff.
Well, they all go to trauma centers.
Okay.
We have 2 trauma centers up there in Aurora.
So you'll go by St. Mary's, which is, St. Mary's isn't a trauma center, no. But it's closer.
It is the closest.
Okay. So they don't even do, like minor stuff, like, all right, obviously in the valley, St. Elizabeth, Ascension, St. Elizabeth gets some traumas.
They turn away a lot of those.
That's okay. That's why I'm asking.
If you call them and try to bring them there, they'll one likely turn you away, so you pre-warn them.
Okay.
Ahead of time, if they really want to go to St. Mary's, they'll say, well, we'll call them, but they may divert you to St. Vincent's. So
Okay.
I'll usually do that before I leave.
St. Mary's and St. Vincent's in the same hospital system?
Yes.
Okay. So at least you don't have that issue to
Some
deal
of the
with.
doctors are the same too.
Okay.
They work both hospitals.
Okay. All right. So you probably don't have as many issues. I mean, they're all going to the trauma center, whether they go by ground or by air. I mean, there's not too many alternatives.
Really, the only problem he has is the aircraft being called, because a lot of times the first responders are police calls before we even arrive at the center.
Yeah.
Because we have in some of our farthest areas, it can be over 10-minute response time.
Yeah, sure.
So, and then we show up on scene and we don't do it.
How's the decision made between St. Vincent's and Aurora?
Depending on where we are, if it's closest or patient choice, if
Okay.
they can make the choice.
And how much longer is it to get to Aurora?
That depends on where we are.
Yeah,
I mean,
okay.
if we're right in the middle, it can be in the middle.
Okay, all right. So how about crews running out in Wapaka, New London? What are you guys seeing with these rural traumas? How do they determine going to Wapaka, New London, trying to go all the way to the valley?
Well, doesn't it depend on if the hemodynamically stable? If they're not.
That's what I'm asking, because this is, I mean, sometimes hemodynamically stable needs the closest one, more than it can even survive driving sometimes 35, 40 minutes in the weather. That's why I'm talking to you guys. And let me preface this, it's quite interesting. For nearly, I've done this almost 21 years now, for the nearly 18 years of my career here, I never saw a single person go directly from anywhere west of New London all the way to the valley. Yeah. And now it's not uncommon. We get traumas, they're wanting to drive strokes, and I'm trying to work with you guys and work with the hospitals on making sure how we do this with good quality care.
I think some of it is the provider's comfort level in the ED, and some of them would rather turn away so that they don't have to lay hands on.
That I can't argue with. Sometimes I use that as is in the patient's best interest. Okay.
That's not fair to the paramedic either, or the patient, because if the patient's unstable, and you drive 35 miles versus 5 miles, it's stabilizing.
Well, then you got to let the doc know that, listen, the patient's too unstable. I need to come get them stabilized.
I think that still goes back to the provider sometimes in their interpretation of how they can justify that someone's stable.
Yeah. Yeah, no, I don't argue, because that's what brought this up yesterday. We had a long discussion about this, and happened to be a case that was near New London, you know, and the nurses were irritated that they brought it in, and I said, so we reviewed the case. The vital signs were not unstable, and that's why we utilize vital signs and hemodynamic criteria, not just how bad does the crash look, you know, so. And we go over things like it's not just about a low blood pressure, particularly in young individuals. Before their blood pressure goes low or becomes hypotensive, what would you see? Yeah, resting tachycardia, anxiety, sweating, and sometimes even tachypnea, so fast breathing. And it's interesting how they how that sweating. You know, keep an eye on patients that sweat, and I've got a good video that talks about that later on. So you always be cautious. You got somebody that's got a blood pressure of 110/70, and their heart rate's 120 to 130. You got to be very cautious about what's going to happen next to them. And so, I don't have a real good solid answer. That's why it's, you know, in the protocol to utilize, contact the closest provider. Talk to them about stabilization, and they may send you all the way to Valley. I don't really have, you know, one way or another that I can give you guidance that says, no, we absolutely have to stop, you know, because like you said, if the provider's not comfortable, once he gets in there, that's not going to help the patient at all. Yeah.
What about this for a possible solution? Let's say we're out in a rural area, New England or Paca, and we have the issue that Mike just brought up, is the provider's not comfortable with it. What about if we have an unstable patient, or if we get a hold of maybe the helicopter?
Well, sure. However, like we've seen quite a bit in the recent, the aircraft's not able to fly.
If it's reasonable.
Yeah, many of these cases, the problem is the aircraft's not available. And that's what was going on with the case we were talking about yesterday. And I mean, if the aircraft's available, there's any number of things you can do. Bring them to the scene. If, depending on where you're at in Wapaka, you can meet them at the helipad in London. I mean, there's all sorts of things. You know, that makes it a whole lot easier. It's those, you know, vicious snowy nights, or even sometimes during the day. Why is it they like to crash so much at night? I mean, I'll tell you what. No, dilly. Yeah. Sorry, I'm going to use that a lot today, because that was my favorite commercial during the Super Bowl. And I think that's about all I saw of the Super Bowl. I'd get 5 minutes and I'd go watch the Super Bowl. There'd be another Bud Light commercial. I don't know. So, but nonetheless, yeah, it's the challenge when the aircraft's not available. And then there's always that question, you know, what's in the best interest of the patient? And when I take these phone calls as for the ER, you know, it's like, and I told the crew yesterday, it's like the Snoopy cartoon. You know, when you're in class, what do you hear? Whack, 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 whack. You know, the patient needs help, the patient needs help, the patient needs help. You know, he's not calling me for my advice on which x-ray to do and, you know, should I give more blood? He's calling to get him out of there because he one way or another doesn't feel comfortable. And that's fine. And that's really, you know, you're going to get the advantage the crew didn't get yesterday. So we're going to use some Super Bowl analogies. So do you think anybody went into the huddle near the end of that game, like particularly for the Patriots, and told Brady, do not pass the ball to me? You know, they want their number to be called. You know, and the healthcare is really unusual. As a commercial endeavor, do you realize that we're the only group of people that celebrate no work? No, we are. I mean, you know, and I'm no different. I really, let's see, anybody in my ED that works with me? Yesterday I had too many moles. Yeah, Jason was here. Oh, all right, Steve, we'll pick on Steve because he's working with me. I mean, I'm not happy to see too many patients after 4 a.m. I'm no different than you guys. However, I mean, you know, if you were owning your own restaurant and, you know, it was 4 in the afternoon and there was nobody in there, you go, I wonder what we're doing wrong, you know? You gotta get the calls, you gotta get the people. We celebrate when people leave AMA. Oh, another one left AMA, and that's the best we got. That's the best we got. You know, can you imagine if, like, you take it to the, let's use Best Buy. You know, they spent 45 minutes looking at a television, and you answered all their questions, and they walk out without it. You go, okay, so where's he going to go buy this thing? 'Cause
Amazon.
Amazon, Costco, any number of things, but, you know, healthcare is really strange that way. But we gotta put our best foot forward to make sure that we're doing the best that we can, in spite of other people's downfall. It all comes back to EMS, quite frequently. I mean, we're the first ones called, we're the ones that are called when shit's hitting the fan, we're the ones that are called when people need to get people from one place to the other, and it's usually not because they just need a ride. All right, and that's where we gotta step up to the game, and we gotta be the best that we can be, and deliver on that, so. All right, that's a good discussion. Any other thoughts about that? Because, I mean, I'm seeing strokes driving all the way from west of New London. I don't recommend it, particularly stroke. I mean, please, you know, I'd take them to the closest. They can scan them, they can all scan them, get a negative head CT for bleed and start TPA. I mean, there's just no reason for them to drive 35, 40 miles. In fact, that brings up something. So a lot of what we're going to go over today, I try to put this right after I attend the National EMS Directors Meeting. And some of the stuff I had beforehand, some of the stuff I bring back there, because I don't want to put this whole update or lecture together with old material for you. And so we're going to see a whole section on quality today, because the conference was broken down into daily topics. And the first whole day was on quality. All right, so quality, if you haven't seen it, is hitting all of healthcare. And it's going to be a matter to determine how we get paid. You have to demonstrate your quality. We all believe we deliver quality, but there are certain guidelines and metrics and benchmarks. And so that's eventually how we're going to get paid in the future. I don't know how they're going to do it. I know the goal on the part of the government is to find a way not to pay us, and that's not a lie. I mean, they don't tell you we're going to pay you this much, and then if you hit a quality measure, pay you more. That's not how it works. They say, if you meet all the quality, we will pay you this much. If you miss this one, you're going to get this less. If you miss this one, you're going to get this less. You're going to get this less. You know, so when the front office is talking to you about all the stuff you got to do, I mean, I'm serious. So, and just to give you an example, my chart on chest pain, I have to have a statement, line item statement, if I gave or didn't give aspirin and why. You know, my statement is quality indicator, and it's a bolded dash. Aspirin administered for chest pain. Boom. And if you guys gave it, it'll say aspirin not administered for chest pain because provided by EMS. You know, and I put it completely with a line in front and a line below, so that my coders can find that, so they can check that box. You know, my EKG done within 5 to 10 minutes, and it's interpreted as. You know, these are the things that they're going back and checking, because if they don't see them, they go, oh, well, we can take off $5, and we take off another $5, and take off another $5, and that's going to come to EMS as well. There are going to be things grading response times, they're going to be grading scene times, they're going to be grading quality things such as how fast was the EKG, aspirin, sets of vitals, that sort of stuff. All right. Now, one of the things they brought up in this meeting, as we're talking about stroke, is mobile CT scanners. And this started, came to this meeting 2 years ago as a concept. And the neat thing about this meeting, they make it fun. They do a point-counterpoint. It's an old thing that used to be on television years ago where two people would debate things. But they had somebody who was on the pro side and somebody that was on the con side. And they brought it up 2 years ago as something that hadn't been researched. And what would your thoughts be? You know, putting a mobile CT scanner on the street, well, what's the cost of that? How many people can it service? What happens if you get 2 calls or more calls than you have scanners available? That sort of stuff. And so at the time, 2 years ago, nobody really thought that it was much benefit. Well, this year they bring it back, and they've actually researched it. Now, they researched it in a very large urban environment. I understand there may be one in Chicago, but this was done in Houston, Texas. And their metrics actually were very enticing. They're very intriguing. They actually had better, door to CT scan times than their EDs. They also had better door to intervention time than their emergency departments. Now, why would that be? I mean, you're taking a CAT scanner on an ambulance and you're driving it. There's really only one. You got to drive it for whatever distance, and you're in traffic and such. How do they do that?
Cutting out a lot of the variables of the ED itself.
Like what?
Patient load, staffing,
Yeah.
the ability of the CT scanner to actually be available.
Yeah. Have you been in Houston? All right. So the interesting thing is, the medical director for Houston Fire, who I know very well, he said, in our emergency department, even if you announce a code stroke, you can't get someone on a CAT scanner for up to an hour. Ah. Huh. Opportunity. Yeah, so the fact that you actually have a mobile CT scanner that's dedicated to stroke, there's an opportunity. And that's sort of the thing that left it open. And they've done some things that help it. Initially, they were sending out the CAT scanner with a radiologist on board. It was a radiology resident, but nonetheless still a radiologist. Now they're able to, through mobile broadband and such, actually send the images, teleradiography. So that helps to reduce the cost. They can initiate TPA, so they do that. So they get a negative head CT for hemorrhage, and they start TPA, and their door to intervention time. And they actually bypass the ER altogether. So they're actually getting high screening of the patients. And as we all see, and we've taken care of, not all of them are strokes. I don't know the percentage. I'd like to see some research behind those where EMS has, put a preliminary concern, I don't want to say diagnosis, of stroke or a stroke-like syndrome. How many are true hemorrhages, how many are something else, and how many are strokes. But nonetheless, I talked with him afterwards, and I can see in this area, potentially within 10 years, having a mobile CT scanner. Particularly as the EDs are only going to get busier and busier. I don't see any way that the emergency departments are going to get less busy. They're already, the only one that's not too small is St. Elizabeth's Ascension, because they can flex up to another 20 beds. I know they're pretty packed now, how common is it for you guys to have to stand in the hallway at Theta Care and Nina and Theta Care and Appleton? Right. This time of year is bad because it's real busy with influenza. We're very lucky so far. Not that you can put tents outside of a hospital in this weather, but they are having to put up, literally military-style mobile hospital units in some of the larger cities because they're really hit hard with influenza. I don't think it's terribly widespread, but there were a couple of those on the news. All right. Any questions about stroke? How's it going with the activations? Stroke and the Pulsera working well, communicating well? Okay. Seems to be working fine on the hospital side. They just can't figure out the noise of the phone. I don't know if it still is a siren. It used to be a siren and somebody thought it was on the television. And then the ambulance showed up and goes, oh, what's that? Oh, that was the noise on the phone. It's like, no, it wasn't a television show. But nonetheless, all right. Do you see any variability when you take a stroke to Ascension versus Theta Care and Nina? Which one's better at getting them right to CT? Because that's one of the things they talked about, how many are getting your patients right to CAT scan. Have you been
When
able
you
to
take
do
them
so?
when you take them to St. E's, they tend to draw blood and do like a preliminary triage and exam right in the, like right as you're coming in. And I don't,
Okay.
I'm not saying it's a good thing or a bad thing, but that's what they do.
I've had
And
both,
most-
I've gone straight to CT at St. E's and Nina, and I went to ED beds first at both of them.
I think it's all how you present it in your report.
I know it's how you present it, and I also know that it's based on providers. You know, and Steve's gonna get picked on because he's worked with me in the actual emergency department, but there's just nothing that you gotta do before that first CT.
Right.
I mean, you can get on, you know, like, you know, let's dialogue it, you know. What blood test do you need?
They do a creat.
Yeah.
think
Oh, I
that's
know,
probably-
but
Well,
that's
yeah,
it,
but there's nothing
So we all
you
do
need
that,
prior to
but I
that,
mean, right.
that CT.
Yeah,
That
that's just
CT
for
is
your
what you need.
contrast. So you can do
That's
your
the point
non-contrast
of
without
care,
doing
we do that one, and that one can be done either at the CAT scanner, but the point is, there's not a lab test that's gonna identify, as opposed to, let's flip this around. Let's say you have a non-ST segment elevation at line. We don't know about that for 2 hours, because we're waiting for the troponin. So, I mean, in that case, let's say CT, you say, let's get a lab test or a CT, not that you need a CT for chest pain, but, well, we get the lab test because we gotta get that cooking, because that's gonna tell us if the troponin's elevated.
Right.
In stroke, the main thing is, yeah, the creatinine, don't get me wrong, it's very, very important, yeah. And the CAT scans, you know, anyone done decision trees where you come down to a point you have to go and split off? Yeah, so stroke, the decision tree is CAT scan. Bleed, we go this way. No bleed, we got some other options, right? Chest pain, the decision tree, EKG. That's why it's so, it's so paramount to get that EKG so that we can have that decision aspect. So, but nonetheless, you know, they're trying to get more and more people to write from EMS to the CAT scanner. A lot of it's just like you talked about earlier, personnel. All right, whose patient is it? Not our job as EMS to figure this out, but it is a challenge within the emergency department. All right, is it the ER's patient? How many people do we send down there with it? And what do we do with all those people? Because they can't run, you know, how many rooms, when you take 2 nurses or a medic and a nurse down there, how many rooms are shut down? Because they're not gonna get any care. But nonetheless, that was one of the questions that was posed for quality, you know, trying to, and it is a reasonable initiative across the nation to try and get people right to CT. Actually, one of the best places I've ever seen is New London. New London's, they do great about getting people to CT scan, at least the shifts on there. They're very open to it, which is nice to see. Yeah?
I had an interesting case where we responded for a code, and the gentleman had a seizure, was incontinent of urine, all of the neurological signs of maybe a bleed or something like that. We were just a few minutes from Theta, and we resuscitated him, got ROSC, and I was just a couple minutes out and they converted me to AMC. I guess in those situations where he was decorticate posturing, the whole 9 yards, people changes, all of that, directly in front of us. So that was kind of an interesting / frustrating case because we were right there, all the signs were pointing to neuro, which is why he coded, and then we got diverted. So we were just kind of, I guess, a little shocked, you know, to be turned away and then sent up to AMC, and we got to AMC, we went directly to the CT scanner.
All right.
So,
Did you find out what he had?
I did put it across somebody's desk, I don't know,
Okay.
I haven't heard any
All right.
return on that one yet, but.
Well, make sure, you know, Nick and I get that one so I can
Yeah.
follow up on that one. I don't have an answer for you.
And I, a couple times went, are you sure? Because these are the neurological symptoms that I'm finding. Are you sure?
Well, other than a STEMI, I can't see why
It did
we'd send
say-
anything. No, I understand, but I
Yeah.
can't see why we'd send anything, unless they were, you know, overwhelmed for some reason and their CT scanners weren't available and such, but I'll look into it.
Yeah, our post-resuscitation probably did say STEMI, but, you know, a lot of them do. And I don't know, it was just very interesting.
Yeah, yeah.
Well, like with that too, I know trauma trumps STEMI in that situation. Would stroke trump STEMI? If,
I guess that was my question, yeah.
I-
I mean,
I've heard before that they send me first.
Yeah, you're gonna have
yeah,
to,
but he
Says
coded
first.
because of neurological issues.
Do you really
I
know that?
think
Yeah,
so.
They say
Yeah.
or the neurological issues caused by the lack of blood flow in the brain because of short
yeah, you can never tell which one caused the code. I can tell you, because I resuscitated somebody on the streets of San Francisco, and, I'm at an EMS conference, and my wife and I are playing hooky, and we're gonna go down and watch them throw fish around at the wharf. And we're walking up to the, cable car, and there's a gaggle of people, and somebody's in the streets seizing. I go, that's not your run-of-the-mill seizure. And, she'd had a primary dysrhythmia, and, had I suspect some sort of dysrhythmia or arrest. And we got her resuscitated, but nonetheless, it was, everyone standing there thought she had a seizure. But you never know what causes these things, so you gotta look into them. All right, very interesting case. I can't tell you why you got diverted. I would treat STEMI first, because your options for stroke are gonna be, they're systemic. And so, they can be addressed actually at the same time and very soon. But if that heart is dying, the brain's not gonna be any good for you. So you gotta get that heart, stabilize that heart, but.
So essentially you would have diverted as well?
Not necessarily, no, not unless you have STEMI on your EKG.
We did, the 12 we did show a study.
Oh, I'm sorry, I didn't hear that
Yeah.
initially. I thought you said post-resuscitation. I don't know. I mean, personally, I'm a guy that brings them into my place, sees what I got, tries to stabilize a few things, and then I can try and get some, because there are other things that cause ST segment elevation on EKG other than just heart issues. I can understand why AMC did go right to CT scan, because you're not going to be able to do a heart angiogram with heparin if there is a hemorrhage. So that I know that's exactly why they did that. Well, that'd be a tough call to make, especially since you're a couple minutes right outside theta. Okay. That's why the protocols can't be written for all things and all people. All right, so when we look at stroke, we look at STEMI. How about Pulsera with STEMI? I actually met with the guy who developed the Pulsera at this meeting, talked to him quite a bit. Does that seem to be working well? All right, let me ask you, what happens if we were to start using Pulsera for even EMS communication with the hospital? What would you feel about that?
I'd be disappointed.
Mm-hmm.
You would?
Yeah,
Why?
because you're missing out on a lot of the picture that I can't easily
Text.
relay. I mean, it's just like trying to have a text conversation. That's a great point.
You're not gonna get the tone of
You're not
voice.
gonna get the tone of voice, you're not gonna get all the information. For me to,
Do you want the tone of voice from the ER?
don't worry about it. They can do that on me.
just don't let Craig answer the phone anymore.
Yeah, there you go. That's a great idea.
Just don't let Craig answer the phone anymore, then he won't get that guff.
Truthfully, all we really need to start doing is just giving them an ETA, because nobody that you talk to on the phone talks to the nurse, actually takes the patient anyway.
Would Pulsera asking for a date of birth right away?
I think you got that
Now,
now.
they finally have.
They have it. They have it now. Or is it,
Initially, just
I mean, it's the first thing you have to do before anything else.
Pulsera.
Are you kidding me? They're asking for that? Here I am, working my butt off to have you guys give something clinical before the ID, and my whole staff is asking for something ID wise. Oh.
Yes.
I'd like to clarify, it's not the whole staff.
No, I know. There's always a swing in the pendulum.
I asked him the other day, I said, I tell you what, if you wait to the end of the story, it gets good. But I said, I feel like you're the kind of person to read the last page of the book.
Yeah, all right.
Third time, I was like,
And Craig just complains about you bringing the patient. Yeah, I don't know what entertainment I'd have if it wasn't for Craig. All right, Well, now, the reason I'm asking is because I was talking with them, and they are developing a product that actually will allow communication to the ED in a dynamic fashion. So it does go based on what you're saying, because the person taking the stuff on the piece of paper doesn't really take care of the patient anyway. So if you put in the important things in there, and then you give some sort of verbal report at the bedside, and that's what I'm talking about. You know, so how valuable is that radio report?
It doesn't, I don't think it gets used very much.
Well, that's the stuff that he and I were exploring. I mean, is it just the fax man? Like the old dragnet? You know, fax, just the fax man. You know, that's all the dragnet guys wanted to know. And if it's a matter of, okay, we got altered mental status, here's their blood sugar, here's their vital signs, and here's our ETA. And what they're looking at is what's called dynamic communication. Who said text messaging? All right, so that's what text messaging is. It's dynamic communication. It's a phone call between my wife and myself that actually may take 90 minutes. No, I'm serious. I mean, I can't take a phone call because I'm in the ER and that sort of stuff. But she says, what time will you be home? Not soon, you know. But you know, I know she wants to know that, but I don't have time to call her and say I'm not going to be home. But I can send her a quick message. I'm not going to be home by 9. You know, and then if she sends back a message, I can ignore it because I'm busy until I can actually answer it. And this is something that's, you know, modern levels of communication, dynamic communication, does allow. You can actually put in some stuff, and like one of the first things you may know, and it actually can help the emergency department, is that you know they're going to go to, let's not always pick on Theta Care and Ascension St. Elizabeth. And you may be, you know, they don't even know where you're at. I mean, you know, it's kind of fun. I love the pulse point, particularly at night, because I listen, you know, the tones still go off and you can hear them from the garage. And I try and figure out where the ambulances are. And you guys are spread all over the place. You know, I'm getting 7 down in Neenah. Well, what do you get? Who are you guys? Well, you're all the way down here because the whole system's all dynamic, it's constantly shuffling. All right, so the fact that you might have an ambulance coming in and you might know about it, so let's take Island Shores. I mean, it's, you know, literally, you can see it, it's been spit to the hospital, but when you guys are at the bedside, you know you're going to Neenah, you would select patient, you'd put in Neenah, Neenah would know there's a patient coming. And then you can add the other stuff later as you get it, but at least there's that dynamic communication.
So conceptually, I don't think it's a bad idea. Conceptually, I didn't think that Pulsera was a bad idea for subsystemies and strokes. You know, radios aren't going to go away.
No.
The emergency department line's not going to just disappear. So there is an option where if you get a patient who isn't simple, where you want to give a better detailed report or pre-hospital report, you can call. That being said, looking at Pulsera, dealing with Pulsera for STEMI and stroke activation, I'm not sure if it's baked enough, to turn a phrase, to use for everything yet. On both sides, not only like hospital using it and EMS using it. It's an app that it's not the worst, but it could be definitely more efficient.
Oh, it's not what you see. It's completely different from what you see.
For
the
regards to what?
For the total communication.
Yeah.
Yeah.
So
we haven't seen it here yet.
Right. So my point with that whole thing is if there was a system in place for that, I think that it may be really good if it was actually baked enough and tested enough to kind of go out and do what it's offering.
As long as they don't politely ignore us like you do your wife.
Yeah, that ignoring thing goes both ways. I didn't hear the phone, did you?
Anyone got an iPhone 10? No?
We're paramedics.
No, they, I think it's the software version. You ever try to text somebody that's driving? You ever text somebody with the new software version of iPhone? maybe yours isn't turned on.
Oh, you can turn it off, trust me.
Well, I know you can turn it off, but I
It's turned off
don't,
on mine.
I don't want it turned off. I don't wanna be pestered while I'm driving. I see every day too many people with distracted driving.
To kind of jump with my saying too, I think one of the problems I see with that is for 95% of run-of-the-mill patients, having the text app, whatever you wanna call it, all right, I can see that working out. The 5% that are the major ones that are significant, I'm usually doing stuff and I got the phone on my shoulder as I'm doing interventions or whatnot and trying to make that call. And if I have to stop and go, hold on, let me fill in this darn app, you know, on the STEMIs and all that, you sit there and go, oh shoot, we gotta do this stupid Pulsera, this takes more time.
I think what we would do it is we would work it out, and, you know, we're gonna continue to do what's right over your shoulder. Do what's best for the patient, be the best in EMS. You may have to fill out some of the stuff in the Pulsera, fine, but when you need a phone call, you need a phone call. You know, just like, you know, I've been known, when I got a transfer, to try and let dispatch know that we're gonna send an out-of-town transfer. Because I want them to have as much time as possible. I work with dispatch enough, it's like, it's gonna be doggone frustrating to get a piece of paper and have everybody want you there in 15 minutes. You know, and the poor dispatch guys trying to scramble, and they got a crew that's going off because of the time of night, and they got others that are doing this, and we have no idea what the system's doing. So if I think it's gonna be a challenging transfer, I'll try and give dispatch a little bit of a heads up so that they can make some plans and manipulation. So I think, like John's talking about, the phone's not gonna go away, it'll be there, and we can still utilize it. And I haven't seen exactly what it's like, but I was intrigued enough to know, to say, and it might be really great for 75% of what we do. And it may not work for the other 25%. And a lot of what you're talking about with tone and things, hopefully will be at the bedside, and we'll get a better bedside report, but, you know, I mean.
I guess, if you're talking about the way you explained it the second time, that's a little bit better, as opposed to trying to have like a back and forth conversation, if it's.
Oh, no.
If all we're putting it is like.
Yeah, no, you're just telling me.
Vitals and then.
You're just telling the ED what's coming. No, I don't know how much questions they come back with. Most of that's still gonna be by phone, because you gotta have some recorded, you know, if they're gonna give you an order.
Yeah.
Still gotta get that recorded.